Well, friends, this is our third lecture on policy. In one of the lectures on India's population policy, I presented the broad framework of policy and how policy has evolved over the years. To recapitulate, it was first the Gandhian approach, then clinical approach, then extension education, IUCD, mass vasectomy camps, cafeteria, target oriented and then target free approach. These are all the stages through which population policy of India has passed. We have also seen that in 1976, Dr. Karan Singh issued the first population policy statement, which contained a number of points. He realized that population growth had acquired a crisis dimension and something has to be done urgently. He said that there is a close link between population and poverty. He also realized that actually it is the reduction in poverty and it is the socio-economic development of the country which will ultimately lead to demographic transition, but he said that we cannot wait for that to happen. That may take a long period of time, and since population growth has already reached the critical size, so something has to be done for making a direct assault on the population growth. In this respect, he could think of a number of points like raising age of marriage of girls, raising school enrollment rates, making all girls educated at least up to middle standard, then involvement of all government departments, incentives, research in reproductive biology, research in communication, research in contraceptive practices and attitudes, then group incentives, and there were also some political questions like freezing number of seats in the parliament on the basis of 1971 data and considering only 1971 population data for allocation of central resources to states. That means ignoring 81 and 91 census data for deciding number of seats in parliament or for deciding allocation of central budget to states. Most sensitive point actually, which also led to defeat of this policy subsequently, was the point regarding compulsory sterilization. Dr. Karan Singh assumed that the climate was ready to go for compulsory sterilization after 3 children. The only problem he thought was the lack of facilities to sterilize a large number of couples in short period of time if such a thing becomes a law, and therefore, it was not taken up. But he said that states where they think that the facilities are okay, they can come up with a bill and say that irrespective of caste, creed and community, people would be sterilized after 3 children. Now, when Janata Party came to power, which had fought the parliamentary election largely on the issue of compulsion in sterilization, they announced a new policy in 1977, 1 year after the first policy declaration by Dr. Karan Singh. Now, this said that coercion in achieving the family planning targets led to defeat of Congress party. In the general parliamentary elections, the Janata Party would oppose the sterilization program. Family planning program of India, emergency time, had become a sterilization program, and the Janata Party announced that it would oppose this sterilization program of government of India. In June 1977, they came up with a separate policy. And the most significant part of this policy statement was that the program of family welfare, which was a new name for family planning, would be entirely voluntary. Actually, this change of name from family planning to family welfare itself shows that there is a change in stress from some kind of compulsion in sterilization to a family planning program which is entirely voluntary. that it is up to the couples to decide how many children they should have, when to stop them, and which methods of family planning they should adopt. Government will only facilitate means of doing so. Now, the opening para of the policy statement in 1977 was like this, that the President in his address to Parliament on 28th March 1977 stated that family planning will be pursued vigorously. So, there was no withdrawal of the program as such, but it was made a voluntary program. To quote, that family planning will be pursued vigorously as a wholly voluntary program and as an integral part of a comprehensive policy covering education, health, maternity and child care, family welfare, women's rights and nutrition. The Prime Minister has on a number of occasions underlined the vital importance of family planning as a means of individual and national development and well-being. This government is totally committed to the family welfare program and will spare no efforts to motivate the people to accept it voluntarily in their own interest and in the interest of their children as well as in the larger interest of the nation. So, as the policy document, as any document of government is drafted by bureaucrats and their perspective on population had hardly changed. So, this new policy also said that there is a close link between population and development and that there is a need to pursue family planning program in the interest of both individuals and state, but the program will be pursued in a voluntary manner. This was the voluntary nature of the program, which became a major point of shift from the earlier policy. So, otherwise, if you read the original document, original policy statement issued by Janata Party, you find that most of the points are similar. Points regarding age of marriage, points regarding education, all the points are similar, except that there is a change of emphasis to voluntariness of the program. Now, this opening paragraph was followed by this, that the family planning program has however to be lifted from its old and narrow concept and given its proper place in the overall philosophy of welfare. It must embrace all aspects of family welfare, particularly those which are designed to protect and promote the health of mothers and children. It must become a part of the total concept of positive health. At the same time, it must find meaningful integration with other welfare programs, namely nutrition, food, clothing, shelter, availability of safe drinking water, education, endeavor to bring about this endeavor in a greater degree. We expect the state to do the same. Then it says, the change in the name of the program from family planning to family welfare is a reflection of the government's anxiety to promote through it the total welfare of the family and the community. It is our intention to take the program forward in the real sense as an investment in man. We wish to make it abundantly clear that in this task there is no room for compulsion, coercion or pressure of any sort, things which were attempted during the emergency time by the Congress regime. So, compulsion in the area of family welfare must be ruled out for all times to come. Our approach is educational and wholly voluntary. There will, however, be no slackening of our efforts in this direction. So, there are you see there are two things. One, a promise that there is no slackening of our efforts in population control, and second, that the days of compulsion, coercion or pressure of any sort on couples to accept family planning are gone. The government attaches the highest importance to the dignity of citizen and to his right to determine the size of his family. We have no doubt that by and large the people of India are conscious of the importance of the responsible parenthood. Given the necessary information and adequate services, they will accept the small family now. We will promote all methods with equal emphasis and will be left to every family to decide what method of contraception it will like to adopt. So, are they not talking of cafeteria approach? In vision or strategies of family planning, there was hardly any change. They were talking of the same thing of which the earlier draft mentioned, except that the coercion was replaced by voluntarism. So, they said that we will promote all methods, means we will use cafeteria approach with equal emphasis, means there will be equal emphasis on terminal and spacing methods, there will be no extra emphasis on sterilization. Depending on their needs, couples may use spacing methods or terminal methods. To quote, we will promote all methods with equal emphasis and it will be left to every family to decide what method of contraception it will like to adopt. Employees of the union government, state governments, autonomous bodies, local bodies, etc., will be expected to set an example and to adopt the small family norm. Actually, I do not find much difference between the previous draft of Dr. Karan Singh and this draft when it comes to this point. And one can say that it was largely a political change in the drafting of the population policy statement. Further, it says we are totally against any legislation for compulsory sterilization either at the central level or by the states. Sterilization both of males and female is a terminal method and suitable for those couples who have reached the optimum family size. Services for sterilization will be offered free of cost to those who voluntarily wish to adopt this method. Similarly, other services under the program will be available to the people free of charge. The acceptance of voluntary sterilization and IUD involves to and fro travel to a clinic, a brief stay in the hospital, resulting in possible loss of wages, which the majority of people cannot easily afford. In view of this, it has been decided to retain the provision of monetary compensation. Same thing as incentives. In the earlier draft we had incentives, now they are saying monetary compensation. So, idea is same. Any medical complication resulting from a voluntary sterilization operation will be attended to free of cost, and if in an unfortunate case recanalization becomes necessary, this facility will also be offered to the individual concerned under the best possible professional care without any charge. We know that in India it is very difficult to implement these things, but at least an assurance was given that suppose somebody has 2 or 3 children and is sterilized and unfortunately something happens, accident or some disease, epidemic something, and his children die, then government should provide all the. Next, it says that nearly 80% of the population lives in villages. Medical services are not able to reach them in an effective way. An integral rural health scheme is on the anvil and will be implemented shortly. It is of the utmost importance that adequate antenatal, means before childbirth, natal at the time of childbirth or delivery, and postnatal care after childbirth, after delivery, is made available to pregnant mothers. To this end, antenatal means checkups, referral, iron and folic acid, tetanus toxoid injection. During delivery means institutional delivery, proper medical care at the time of childbirth. Postnatal means handling PPH, postpartum hemorrhage if any, care of child, care of mother. To this end, a comprehensive scheme of training of indigenous midwives will be implemented. Under it, maternity services will be made available to all mothers who will need them anytime. The program of immunizing children against common diseases such as whooping cough, diphtheria and tetanus will be extended further. We expect that the state governments will give necessary cooperation and assistance in this direction. So, this was the Janta policy. What I want to say, I have not brought other paragraphs from that scheme, because those paragraphs look very similar and sometimes exactly same as the paragraphs of the first policy drafted by Dr. Karan Singh. So, the goal is same, commitment for population control program is same, involvement of central government, state government employees is same, incentive, disincentives is same, equal stress on all methods, terminal spacing, everything is same. The only difference is that at least for political purposes, they showed that now family planning program does not have compulsion to go for sterilization, and it has become a voluntary program, that the individual couples, after they have realized the need to go for family planning, terminal methods or spacing methods, can do so, and government will provide all the facilities. Government will particularly provide facilities of reproductive health, education, family planning services and recanalization if there is a need for doing that. Now, in 2000, so between 1977 and 2000, lot of debate, discussion, research was done on the matter of population control. We had better in 2000, we had better data, better analysis, involvement of so many civil society actors, NGOs, research centers, private research centers, government research centers, population centers, IIPS in drafting of policy. The policy was circulated for comments among bureaucrats, academicians, civil society actors, and finally, a national population policy 2000 was announced. This was in 2000, as the name of the policy itself shows, NPP 2000. In year 2000, Government of India passed the national population policy, which was named NPP 2000. You have the complete draft of NPP 2000 on net is still available. Somebody can see the whole policy draft on internet. It emphasized need for promotion of contraceptives once again. This was not a new point, always right from the beginning, right from 1952, we have been emphasizing again and again need for promotion of contraception. So, same thing was done once again, but as a matter of choice and in the target free environment. So, there is no target for different methods of family planning, but there is a need at the national level, state level, a need was emphasized for promotion of contraceptives. Now, by this time planners had realized that target oriented approach does not help, because it leads to poor quality of performance and cooking up of statistical data. We used to call it fudgification. It leads to fudgification, and there is a tendency on the part of health functionaries, CMO or grassroots workers, health workers, to show a number of cases of sterilization falsely. Actually, those cases have not occurred, and there was also economic vested interest that by showing that 100 cases of sterilization have been done, it was possible for health workers to collect incentive money or monetary compensation for all those 100 cases and distribute among themselves. So, on the one hand it satisfies the requirement of target, and on the other hand it leads to making money on the part of health workers, illegal money making, and this was going on. So, NPP 2000 says that we believe in quality performance, real performance. We do not want just to show on paper that a number of sterilizations have been performed. We want quality statistic, quality acceptance. and those who want to limit family size are anyway doing this. Development aspirations have made people quite conscious about the need for limiting family size. It was also realized that due to socio-economic development, modernization, westernization, a large number of couples are already using contraceptive methods. The program must particularly focus on meeting the unmet need. This became a new buzzword population literature, unmet need, that is providing services to those who do not want more children, but have not found a suitable method. They must be provided required services. I remember around that time Operations Research Group, Dr. Ami Khan, who was the leader of Operations Research Group, and I am very happy to note that he was also PhD from our place, HS department of IIT Kanpur. He conducted a small research, a qualitative research on the causes behind unmet needs. Dr. Khan found that there are a number of couples in both urban and rural areas who do not want more children, but still they are not practicing family planning method. This was unmet need. What are the reasons? There are various reasons, and these researches by Khan and others brought out all the factors behind unmet needs for family planning. It was shown that NPP 2000 takes a more positive stand. It says that we must help the individuals, we must help the couples, we must help the population in meeting its need for family planning, which anyway has been created by forces of economic development and modernization. To quote NPP 2000, National Population Policy 2000 NPP 2000 affirms the commitment of the government towards voluntary and informed choice and consent of citizens while availing of reproductive health care services and continuation of the target free approach in administering family planning services. The NPP 2000 provides a policy framework for advancing goals and prioritizing strategies during the next decade to meet the reproductive and child health needs of the people of India and to achieve net replacement level TFR by 2010. It is based upon the need to simultaneously address issues of child survival, maternal health and contraception, while increasing outreach and coverage of a comprehensive package of reproductive and child health services by government, industry and the voluntary non-government sector working in partnership. In NPP 2000, a number of socio-demographic goals were created. The goals are meeting the unmet needs, making school education up to age 14 free and compulsory, reducing infant mortality rate. So, these goals tell you on which parameters there is a need to make intervention and how much needs to be achieved. So, there are targets, but these targets are more in terms of socio-economic development and not purely in terms of statistics of sterilization or family planning acceptance. So, infant mortality, a goal in itself, whether family planning or no family planning, you need to reduce infant mortality and the goal is to reduce it to below 30. Maternal mortality ratio to below 100. Even now we have maternal mortality around 300 and infant mortality in 50s. It was said that there is a need to reduce them, maternal mortality ratio to below 100 and IMR to below 30. Nobody will contradict this. Who can oppose these types of goals? Similarly, achieve universal immunization. There cannot be any political opposition to universal immunization of children against all vaccine preventable diseases. Then delayed marriage for girls, not earlier than 18 and preferably, another thing was added, preferably after 20 years of age. So, below 18 it is illegal, but it will be good if the minimum age of marriage of girls is raised to 20 years. Then achieve 80% institutional deliveries and 100% deliveries by trained persons. There is a difference between institutional delivery and say safe delivery. All those deliveries which take place in health facility in any institution, maybe PSC, CSC, sub center, maybe in private hospital, maybe in Janana Hospital, they are all called institutional deliveries. In addition to institutional deliveries, if some deliveries are held at home, but they are held in presence of a trained nurse or midwife, they may also be called safe deliveries. So, the goal was that we will have 80%, minimum of 80% institutional delivery, and all 100% deliveries should be safe. There should be deliveries by trained persons. Similarly, achieve universal access to information, counseling and services for fertility regulation and contraception with a wide basket of choices, all choices, condoms, IUCD, jelly, diaphragm, copper T, vasectomy, tubectomy, injection, everything that is known in the program must be known by the people. Then 100% registration of births, deaths, marriage and pregnancy. Then contain the spread of HIV/AIDS. This was a new point. The earlier policies were missing this, because at that time HIV and AIDS did not exist. Now, in 2000 policy, when this 2000 policy is drafted, HIV virus in India exists and is about 15 years old. So, there is a specific mention of HIV, and promote greater integration between the management of RTI, STI and the National AIDS Control Organization. As a matter of fact, in recent times, more than promotion of sterilization, this treatment, testing and treatment of RTI, STI has become a more important issue in government health program. Then prevent and control communicable diseases. Integrate Indian systems of medicine, means Ayurveda, etc., in the provision of reproductive and child health services and in reaching out to households. It was believed that Ayurveda, Unani, Siddha, homeopathy, these systems of medicine are quite popular in the country, and we should make use of these systems in the reproductive and child health services also. Then promote vigorously the small family norm, so that replacement level TFR can be achieved, and bring about convergence in implementation of related social sector programs, so that family welfare becomes a people centered program. There were 12 strategic themes. They are decentralized planning and program implementation, convergence of service delivery at village level, which is part of decentralized planning, empowering women for improved health and nutrition, child health and survival, meeting the unmet needs for family welfare services in both urban and rural areas. Meeting the unmet needs for family welfare services, especially, first they mentioned urban and rural areas, and then they say especially, particularly among urban slums, among vulnerable sections of society, among illiterate people, poor people, isolated, marginalized, backward, disadvantaged sections. So, who they are? Urban slums, tribal communities, hill area populations and displaced and migrant populations, and also adolescents, and securing increased participation of men in planned parenthood. So, two things. So, in this bullet two things are said. One, meeting the unmet needs for family welfare among all disadvantaged sections of society in urban and rural areas, and second, that so far in our patriarchal system, family planning was seen as the responsibility of women at the household level. Now, they say that efforts should be made to involve more and more men in securing, they say securing increased participation of men in planned parenthood. So, RTI, testing, treatment of RTI, STI, family planning, in this there is a need to include more and more men, because we are a male dominated society. Then diverse healthcare providers, then collaboration with and commitments from non-government organized, civil society organized, NGOs and the private sector, involvement of private, these days another term has become very popular, public private partnership. In the 11th 5-year plan, in almost all respects in education, rural development, skill building, PPP, public private partnership. So, in family planning also in population control program they talked about public private partnership, role of civil society. Then mainstreaming Indian systems of medicine, Siddha, Unani, Ayurveda. In Kerala state of India, Ayurveda is very popular and people from all parts of the country and from outside also, from other countries also come to Kerala for treatment of terminal cases, chronic cases, problems like complicated problems, all kind, for which allopathic doctors abroad or in India, in AIIMS or in Apollo or other sophisticated institutions of allopathy have said no. And I have heard, I do not know, I have not gone to such facilities in Kerala, but I have heard that many cases in which allopathic doctors had said no have been recovered after using Kerala's Ayurvedic and herbal treatments. Then contraceptive technology and research on reproductive and child health. Then contraceptive technology and research on reproductive and child health. Then information, education and communication. Information about facilities, education, complete comprehensive understanding of issues and communication. Communication means change of behavior. So, people must be informed. For example, in case of HIV/AIDS, people must be informed what is HIV, they must be educated, they must have a complete comprehensive knowledge of transmission of HIV virus, and there must be communication, means change in behavior, and information and education must produce change in behavior. So, this is clear. If you read NPP 2000 today, when you go home see NPP 2000 on net, you will find that in 2000 there is a paradigm shift. One can say, to use sociological language, that there is a paradigm shift in population policy. The NPP 2000 has made family welfare a new responsibility of village panchayat. This is what decentralization means, planning at the village level, planning at the earlier for population control we planned at the national level. Now, since the socio-economic, cultural, political situation varies from one part of the country, since information, education, since unmet needs vary from region to region. So, and in regions to region, district to district, block to block, village to village. So, it was said that NPP 2000 should make family welfare a new responsibility of Panchayati Raj institutions, village panchayats. Village panchayats must plan, village panchayats must provide education, information, and village panchayats must provide facilities. So, village panchayat must ensure that there is no unmet need for family planning. Now, these Panchayati Raj institutions are expected to develop area specific need based approaches to reproductive health services. It is believed that empowerment of women, political, economic and social, would strengthen this process further. So, for political empowerment you have reserved 1/3 or half seats on Panchayati Raj institutions for women. There is economic empowerment, self-help groups, eliciting greater participation of women in employment, in industry, in services, in agriculture, providing equal wages, and preparing them, giving them education and vocational skills to participate in economic field. There is therefore political, economic and social empowerment of women. The new policy suggests preparing need based, demand driven, socio-demographic plans at the village level, aimed at identifying and providing responsive, people centered and integrated basic reproductive and child health care. This was a dream, and I can't say that this has actually happened. NPP 2000 has been implemented by Government of India, but whether this has it can be doubted whether this has happened at the village level. This has not happened, but that was the direction, that was the vision, and that was part of the strategies to control population in NPP 2000. The panchayat should seek the help of community opinion makers. In panchayats, there are formal leaders, formal elite who are the elected representatives of people, different wards, panchayats, and there are also informal leaders, educated people, respectable people, elderly people, and these informal elite must also be involved in the program. So, the panchayat, it says the panchayat should seek the help of community opinion makers to communicate the benefits of smaller, healthier families. We want smaller and healthier families. The significance of educating girls and promoting female participation in paid employment. They should also involve civil society in monitoring the availability, accessibility and affordability of services and supplies. Civil society and informal leaders and opinion makers must also be involved in monitoring what availability. One, availability of services, to ensure that services are available. 2, they are accessible. They are not only available at CSC or PSC, they are also accessible to people at the village level. And 3, they are affordable, that people can that the cost of say if you want to promote condom, then the cost of condom is such that poor people belonging to landless laborers category, tribal category, urban slum dwellers, poor people, they can all afford these services. Similarly, services for childbirth. So, these are the points, three major points: availability, accessibility and affordability. Then there is particular importance of improving maternal mortality. NPP 2000 says that maternal mortality is not merely a health disadvantage, it is a matter of social injustice. Lives of women which could have been saved if proper facilities were available are not saved. This is a grave social injustice. Low social and economic status of girls and women limits their access to education, good nutrition as well as money to pay for health care and family planning services. The extent of maternal mortality is an indicator of disparity and inequity in access to appropriate health care and nutrition services throughout a lifetime. Why are women? One reason behind high MMR is PPS. Why PPS? Because anemia. Why anemia? Because there is inequality in nutrition, and this happens throughout lifetime, during infancy, childhood, when they are adolescents, when they are marrying, they are producing babies. Throughout their lifetime they suffer from disadvantages and malnutrition, and particularly during pregnancy and childbirth, and is a crucial factor contributing to high maternal mortality. So, NPP 2000 also recognizes the role of all facilities, all health facilities, Ayurveda, Yoga, Unani, Siddha, homeopathy, and the role of private practitioners and traditional healers. Interestingly, traditional healers are also recognized, though it is felt that mobilizing the private, profit and non-profit sector to serve public health goals raises governance issues of contracting, accreditation, regulation, referral, besides the appropriate division of labor between the public and private health providers, all of which need to be addressed carefully. So, in principle, government is ready to include traditional healers and private practitioners, but of course, the issues of contracting, accreditation, regulation etc. remain, so that the quality of services do not suffer and women do not suffer from injustice in the field of education and health. Ultimately, The goal is to reach the people and promote low cost health care, especially among the vulnerable sections of society such as urban slums, tribal communities, hill area populations and displaced and migrant populations and adolescents. The new policy also provides space to the conventional strategic themes dealing with contraception and information, education and communication, in short IEC, which are to play an important role in states where family planning acceptance is low and total fertility rate continues to be high. There are some operational strategies. So, there are goals, there are strategies and there are operational strategies. How do we achieve? How do we achieve the goals? We will achieve the goals of NPP 2000 through the following operational strategies. Convert service delivery at the village level. It is a big goal. It has not happened and I am doubtful whether this can happen soon. Empowering women for improved health and nutrition for family welfare services. Then child health and survival, meeting the unmet needs of the underserved population groups, use of diverse healthcare providers, collaboration with and commitment from the non-government sector, mainstreaming Indian systems of medicine and homeopathy, contraceptive technology and research on reproductive and child health. Suppose we can find through research an injection which is completely safe and which can free a woman from chance of conception for say 10 years or 15 years, it will be very good and it will have wide acceptance among all the communities including Muslims and others, in which there is resistance for vasectomy or tubectomy. So, research is very important. It is by research only that we can develop such injections, or by research we need to develop options, acceptable, affordable and safe options for people and providing for the older population, and then information, education and communication. Recently, another important thing that has been added in the population program is the concept of ASHA. ASHA means accredited social health activist. She is not a government employee, she is a health activist, she is a volunteer. For performing certain tasks, she is given certain incentives. Some incentive money is given, incentive for childbirth, incentive for immunization, incentive for family planning, and from time to time government can declare. In different states, governments can declare what should ASHA be given for what kind of services and how much. To strengthen health services in the country, Ministry of Health and Family Welfare has launched a National Rural Health Mission for 7-year period 2005 to 2012, and the mission aims at providing improved health services by strengthening health facilities at various levels, creating a new institution of ASHA at the grassroots level, village level, providing this is one thing, creation of ASHA. Another provision is another institution of providing untied funds to village panchayat. So, certain amount say 10,000 rupees is available to village panchayats for spending according to their own requirements any time for needs related to health and family planning, and then implementation of village health plan. Let each village develop its own health plan, what are its problems, what are the risks, what kind of diseases they are suffering from throughout the year, seasonally, what are the causes, are people allergic to something, are there some endemic infections, is there a problem of malnutrition, is there a problem of shortage of vehicles, infrastructure or facilities, and let the village come up with a plan, health plan, and focusing on 18 special focus states. You know that in the 11th 5-year plan, we were talking about some special focus states, that all the states of the country are divided into two parts, special focus and non-special focus. In special focus states of northeast and Uttarakhand and Jammu and Kashmir, etc., we will have more efforts in the field of health and family welfare. What are the responsibilities of ASHA? ASHA is very crucial now to family planning program, to HIV program, health program. So, let us also see what are the responsibilities of ASHA. Identify pregnant women, assist the pregnant women to obtain necessary certifications wherever necessary, provide and or help women in receiving at least 3 ANCs, antenatal care checkups, including tetanus injection, IFA, iron and folic acid tablets. Identify a functional government health center or an accredited private health institution for referral and delivery. Counsel for institutional delivery. Tell women that give ANC and tell women where they should go at the time of childbirth. Also escort the beneficiary women to the predetermined health center and stay with her till the woman is discharged. Arrange to immunize the newborn till the age of 14 weeks. Inform about the birth or death of the child or mother to the ANM and medical officer. Postnatal visit within 7 days of delivery to track mother's health after delivery and facilitate in obtaining care wherever necessary. Counsel for initiation of breastfeeding to the newborn within 1 hour of delivery, which is very vital to save the child from infection, and its continuance till 3 to 6 months and promote family planning. The breastfeeding has been seen, researchers have shown that breastfeeding acts as a kind of contraception. So, promote breastfeeding, and ASHAs are playing a vital role in improving institutional deliveries in rural areas. There is no doubt about that. The main cause may be money, but this is a fact. Research is done during last 6 months and 1 year. They have shown that the proportion of institutional deliveries has increased significantly. I have myself seen in several field visits that the number of deliveries at PSC, at CSC, in government hospitals are increasing tremendously. The reason may be money, and maybe if you withdraw the money incentive amount for this, then the institutional deliveries may again suffer. But the fact is that after NPP 2000 and appointment of ASHA and through the provision of incentives under National Rural Health Mission, the proportion of institutional deliveries has gone up, and this should improve maternal health, particularly by reducing anemia and reduce maternal mortality ratio, infant mortality rate, child mortality rate and child morbidity. So, there is a paradigm shift. Nobody has an issue with that. In the context of NRHM, National Rural Health Mission 2005-12 and Janani Suraksha Yojana, incentive for bringing women to hospital for childbirth, the situation has certainly improved. To produce a baby is to get 1400 rupees in low performance states and 700 in high performing states, plus money for transportation. But we have also seen doctors at PSC saying that people are more interested now in producing babies than in family planning. Suppose you get 400 rupees for sterilization and 1400 rupees for childbirth, it makes rational to go for childbirth. Only the next census will show whether fertility is increasing or decreasing. It will decrease, we know it is decreasing. Increase in institutional deliveries has also put a lot of pressure on health officials and health facilities, where you find no medicine, no beds, that the staff members are overworked, new staff positions have been released. So, the same number of people are involved in general health facilities and also in child birth. So, the pressure of work on health staff has increased, and this might have led to deterioration in quality of services at most places. The staff is overworked and their number should certainly be increased. More medicine, space, theatre facilities, equipment and materials need to be made available. There is some improvement in these factors also, but not the commensurate improvement. The rate at which childbirths have increased, at the same rate these facilities have not increased. Lastly, it has to be stressed that so far all efforts have been made to reduce fertility. This has certainly produced results. Several states have below or just replacement level fertility, others are experiencing decline. And if India also witnesses the same second demographic transition and its fertility goes below the replacement level on a long term basis, it will also suffer from aging, a risk afflicting the industrially advanced economies of the world. That means that right from now we have to think about achieving optimum levels of fertility rather than low fertility. I think time has come when we should not only talk about achieving lower level of fertility, but we should also think of having optimum level of fertility in the long run. China is facing this problem. China now, due to almost 3 decades of replacement or below replacement level fertility, they have old population, they have distorted sex ratios, problem of women empowerment, rising age of population. Now, China is thinking whether the policy of de-emphasizing family planning program can lead to higher levels of fertility and bringing the fertility levels back to at least replacement level. In the recent issue of Population and Development Review, there is an article on this. Some people think that if population policy is changed, fertility in China can again go up. Some other think that due to modernization and socio-economic development, it is now impossible for fertility to rise further, even if family planning program or cultural or government policy to limit family size or to end this one child policy, something is done. If you do not have one child policy anymore, even then the level of fertility is unlikely to go up. So, these are the things that our NPP 2000 addresses. I think you can ask one or two quick questions, some question which comes to your mind.
Actually, this national population policy emphasizes that there is no coercion or pressure in this sterilization or in family planning. So, I think in the last class, I think we said that mass vasectomy played a very much crucial role for the population stabilization. So, this kind of drastic change in the approach of population, whether it's how it affects the effectiveness of population regulation in the country, whether.
I understand you are saying that before NPP 2000, sterilization was the main method of family planning, and Dr. Karan Singh even emphasized in Janata policy. They said that we will put equal emphasis on all methods, but the fact remains that for some time family planning acceptance declined, went almost to 0 level, and then gradually it picked up. But even when it picked up after Janata policy, when on paper all methods were equally emphasized, the fact remains that sterilization was the main method of population control. And even after NPP, the recent data produced by National Family Health Surveys and other related surveys, district level, state level, national level, show that even now sterilization is the main method of family planning. I think something has to be done about it. What can be done about you have to on paper the policy says that you must increase involvement of males in population control program, and involvement of males means going, if couples decide to go for terminal methods, then increase the percentage of male operations, vasectomy, which is not happening because of rumors, because of social structure, because of various types of fears in people's mind. So, there is a need to attack on the patriarchal nature of social structure. There is also a need to provide comprehensive information about sterilization methods and other methods of family planning, and there is a need to create perhaps more incentives and disincentives for male sterilization or for spacing methods. Somehow government of India think that spacing methods are not so effective and spacing methods are also the methods which can be withdrawn any time. Once somebody has gone for terminal method, then you are sure that for the whole entire life the chance of conception would not exist. In case of spacing, people may drop out. By changing climate more in favor of social justice for women and through education, information, by providing comprehensive education to people, and especially this HIV issue. HIV, you may control population by popularizing or by even emphasizing or by coercing people to go for sterilization, but you cannot check HIV AIDS through sterilization. For HIV AIDS, you have to popularize condoms as so. Spacing popularization of condom will not only help you in population control, it will also help you in arresting the spread of HIV epidemic, and the government is gradually realizing this thing and popularizing this particular method of population control more, not only for population control or reducing fertility, but also for arresting RTI, STI, including HIV AIDS. Let us see what happens in the future. Okay, thank you.